What happens if we flip the traditional way of sharing medical information to the wider population on its head? What happens if instead of letting algorithms or the zeitgeist of the moment order our social media feeds, we go straight to the source of clinical medicine and ask practicing experts what they see day in, day out, and give them an unedited platform to help disseminate practical medical information straight from the specialist. Okay, hello, Dr. Yang Bong Lee. Welcome to Straight from the Specialist. And this is almost not a proper production. Not that you're not proper production value. It's sort of a behind the scenes, hopefully.
Indeed.
And just to paint a picture for the audience, Yang, we've known each other for about 22 years.
Yeah,
we met
20
at
plus
medical.
years.
Yeah,
Indeed.
we met at medical school at UCL.
Yeah, it's been a short yet long time ago.
It feels like it was years ago, but it turns out it was a few decades. Thank you very much for coming down all the way from Yorkshire. And I have briefly explained what I'm trying to do. And I'm boring everyone, but I also want to get as many recordings from doctors. So even if this podcast isn't a hit, in 100 years' time, if anyone unearths these recordings, it would be lovely, I think, to have almost a time capsule of how us doctors, what our values were, how we practiced.
Yeah, that would be a nice one to have, isn't it, in the record, in the archives?
Could you give us a quick introduction, Bong?
Of course. So I'm Dr. Yang Bong Lee. I've been a GP partner in semi-rural practice in North Yorkshire for the last 11 to 12 years. My work mostly consists of an HS general practice, inclusive of covering the local community hospital, as well as the academic scene on educating the future doctors in the forms of third and fifth year medical students in Hull York Medical School and the local trust for the foundation year 2 doctors.
So you're really the backbone, and why I wanted to get Bong in is because I want to really be able to portray how GPs are the backbone of the NHS. And so what I've understood from that is not only do you have an important academic role with teaching medical students and junior doctors, but also, and maybe we can touch upon this later, is that you need to have a thorough understanding as a GP partner of funding and how that helps your local Yorkshire community. But a little more background. So I also want to be able to promote the diversity of the NHS workforce. And I don't think an accent is detectable, but you're not British, and I don't know whether that's on PC. So please don't take offence. But yeah. I want to embrace the cultural diversity of the NHS. And can you tell us a little bit about where you were born,
sure,
and how you ended up at UCL with me?
Yeah, so I was born in Japan, in Tokyo, in a household full of Koreans, actually. Mm-hmm. So I was sent to UK when I was a teenager, just to get a bit more diverse education. And
diverse, but you were sent to a boarding school.
I was sent to a boarding school in a diverse, non-domesticated way, I suppose. Yeah, more international scene. My family kind of grasped onto the importance of being able to be at least bilingual, if not trilingual, quite early on. So I think that really sent them towards my generation being educated in a different system to their upbringing.
Korean education
and Japanese education. At the time, at least, anyway. And so I've been sent here, and I stuck around. And yes, once you qualify as a doctor in this country, it's I found that was the kind of.
Is it boring? Sorry to interrupt. Is it boring to go into why you wanted to choose medicine, or is that less relevant now that we're so old?
I suppose there are various reasons for individuals to have gone into it, isn't it? Quite a common one is you're from a family of doctors, and that was kind of almost a given, or possibly
academically talented.
Certainly. And I suppose when you are brought up in that environment, you touch medicine and health and so on throughout your journey as a child, don't you? And that becomes second nature, and perhaps that's how...
Is there a doctor in your family, Bong?
Actually, no, I'm the first generation, along with my cousin.
Oh, nice.
Yeah, we slightly went a different way to the rest of the family. They're all businessmen, really.
But my father was a doctor, so I'm sort of now second generation doctor.
Correct. Yeah.
And often I find these professions are handed down the generations. But that's very interesting to hear that all your relatives are businessmen, and then two individuals sort of developed into doctors.
I suppose businessman is a term that's also non-PC now, isn't it? Business persons. Entrepreneurs, indeed.
I think it's useful to talk about that because it mentions how your journey
is different.
It's different to current people's motivation and, let's say, the future generation.
So if anyone can hear a Barry White voice, that is Cos, and he's a specialist registrar in paediatric medicine, but with a special interest in allergies. So he's as rare as they get, because we all know, we know, it's a given in this room that we know about training numbers and how unique some individuals are. But I'm sure I'll touch upon that later. Bong, tell me, so the idea of this podcast really is because I've noticed that with my patient population, so I'm a private practice doctor, work in the City of London, and I deal with sports and exercise medicine complaints. So it's a predominantly young population. I'm dealing with 20-year-olds, 30-year-olds. Of course, I deal with 70 and 80-year-olds as well. But the difference that I'm noticing between the different generations is healthcare expectations and healthcare literacy. And I want to be able to provide a form of media, speaking to specialists, to get it straight from the horse's mouth, to almost undo any false narratives there are circulating from unqualified individuals that then, just because they are spread and they may become viral, are taken up as truth. And I want to be able to offer individuals a regular, I'm looking to produce a fortnightly podcast. I'm looking to offer individuals somewhat certified opinions, albeit they're not personalised. That's what you have to get from a doctor-patient consultation. A one-on-one is personalised and bespoke medical recommendations. But I would like to be able to speak to specialists and ask them three things. What one thing would you share with the population? What's the one thing that you would teach your GP colleagues? And then what's the one thing you would like to share with your specialist colleagues, or something along the lines that's super fascinating, a line of research that you think is going to pick up speed? So that's my aim. And I want to be able to help the community, and I want to help educate us, our colleagues, whether it's you, Cos, being an allergy specialist, and medical students and GPs. That's my aim. And just to give you a bit more background, it's often with conversations, just, after work conversations with Cos, that we take for granted what we know in our specialist fields. And then the other person, Cos and I have separately said, what? I didn't know that. And I'll give you an example, because Cos won't speak much on this. But he was saying how that they realised, this Israeli doctor realised that the incidence or prevalence, anyway, was lower of peanut allergies in... Incidence and prevalence was lower of peanut allergies in the Israeli population. And he had managed to figure out why. And it was because one of the weaning foods is like a What's-It crisp, but it's actually based on some peanut substrate. So the children were being microdosed and being weaned onto solid foods with a peanut foodstuff, which meant that they didn't build up an allergy. And so this is now commonly used in microdosing. I'm sure that's a mushroom term.
Well, it's a desensitization.
It's a
technique,
yeah,
isn't it?
exactly.
Yeah.
Now I need the specialist to talk about it. I'm not as eloquent when I'm not talking about my field of medicine. And so when he shares things like this, I find it fascinating and mind-blowing. I'll share my boring things, but Cos finds them fascinating. So I want to be able to reproduce that, record it, and then provide it for others to listen in on. Because medical education sometimes can be really dry, but you need the foundations, you need the basics, don't get me wrong. But I think it's a nice little 20-minute listen on your commute. That's what I'm hoping for. And I really want to chat with a GP who serves the community in many ways, medical school students, junior doctors, as well as patients, and your fellow colleagues. And I want to figure out, I want some tips from you before I embark on this journey.
So I'm not going to say that I'm the most qualified to be able to provide the universal view of all GPs, but as things are, it's the individuals.
I love that
isn't
modesty, which I see time and time again with my colleagues. But carry on. You're not the first to have said that.
But yeah, so I do find these topics really fascinating in general. It's not something that we experience or get exposed to on a regular basis, and what is perhaps routine for you, it has become routine because you are super specialized. You are very efficient professional in that field, and hence it's become perhaps a bread and butter topic for you, whereas it isn't for the rest of the population. So I do find that this outlet would be quite useful in that way. And perhaps just to supplement sort of your starting position that, you mentioned, for instance, that the qualified individuals being able to provide these outlets for information, it's quite important, isn't it? Because it's very difficult to find a source that is more reliable, and to what degree you put weight on the information that you get from a source A against source B. And as you said, quite often social media is an easy way of accessing such information, but then that might have come from a handful of stories as opposed to what is termed the evidence-based medicine, which is actually based on hundreds, thousands, if not far more number of people.
Meta-analyses.
Indeed.
We're talking about worldwide. Well, can any... I don't want to claim that I'm a medical statistician, but it's to explain. We're talking about studies, and we're now doing a study of those studies. So collecting the medical stats from hundreds maybe, and then analysing that. So one of the comparators is I would like to be the Huberman podcast version of the medical world. And I really enjoy his podcasts, but they're of the is it the basic science world if they're talking about red light therapy, and I haven't looked into those papers, and I'll probably cut this out because it will turn out that I'm very off in terms of numbers. But if we're talking about red light therapy, you're 100 maybe worldwide. I don't know how many studies have been done. If you're talking about how your cholesterol levels are normalized or reversed with, these are huge powers behind them. And that too is what I want to be able to emphasize. The consideration that's gone into really giving you, the patient, the best level of advice has taken us 20 years of training, and not only obtaining medical school exams, which are the easiest, I think, in comparison to postgraduate exams, and then, Cos pointed out, continued professional development. We go on to then refine and polish and buff and update our knowledge. And it is almost impossible to acquire the knowledge that we have acquired over a few weeks of Googling. And I think that's the scale that I want to be able to portray.
Yeah, because I personally actually don't mind the individuals taking responsibilities for their own health, and in fact that's quite encouraged, and try to figure out what's going on. But the tricky thing is actually knowing the tree for the forest, really, isn't it? The actual important aspect of the presentation or the issue against what they might have read on the internet, listen, talk to the family, friends, etc. So you've mentioned about statin, the very common position of those individuals who might be needing the statin, statistically speaking, might be that, oh, you know, my parents had the statin, they said that it's awful, it causes all sorts of side effects, and so I don't want to take it myself. Or my neighbor said that it's the fantastic medicine, so I would like it even though I might not need it. It's quite influenced by the individual story, and it's not necessarily coming from that useful statistical analysis on whether you're more likely to gain benefit or not.
So we're the translator, is that correct? That we're trying to translate to the best of our ability highly complex information, but package it up in a way that our patient population, each individual, understands.
I think that's accurate, yes.
And that maybe social media well-being, self-certified well-being types may not have the training of critical thinking to the level that we do, the ability to appraise.
Certainly. I think it comes from a different
literature.
agenda anyway, isn't it? I mean, I'm sure they've got very good intentions for what they're doing, that they are hoping to make positive change, and perhaps they do. But if they apply the same information to themselves, that's their responsibility. They have decided to go along with whatever advice that they've read or heard of. But then if you are then projecting that to a mass population,
you're
then
following.
Indeed, then that gives a whole different tinge to the whole issue, doesn't it?
Because what I want to emphasise, and I'm sure I'll be able to do that over the series, is how when you have a patient that consults with a doctor or a surgeon, clinician, oh, that's an interesting physician's assistant, I'll come back to that, that you are getting a bespoke and a personalised response to your individual needs, which is not the same as reading a study or hearing about another person's story. Hence why your neighbour may get atorvastatin and you may get, is it rosuvastatin?
Rosuvastatins,
exactly.
Pravastatins.
Okay,
yeah,
the
all
list
sorts.
goes on. Oh, my cardiology days are well over, but and that helps explain the difference. Not necessarily that you're getting a cheaper medication. It's not necessarily true that there's a postcode lottery that's playing into your care. Of course, these narratives are true, but I want to also highlight that other narratives are true, that we're offering individualized bespoke medicine, which everyone is talking about AI taking over the doctor role. I can't imagine that would be the case in the near future. I just want to be able to clearly, paint a picture so the individual understands that we aren't following algorithms or guidelines. There's a complex set of reasoning, and maybe I'll speak to a neuroscientist because maybe there's better language that we can use. But that's what a patient-doctor consultation is to me, and it can't be matched.
Well, I would say
with Google searches.
Well, I would say the guideline is a guide, right? We do have guidelines, and some people do follow those guidelines, but they are just a guide. And at the end
safety
of the day,
nets.
Yeah, and you it's to set a standard. And at the end of the day, if you look at the individual for a personalized medical plan, then you will think outside the box and you will take into consideration things that are not, let's say, perhaps listed in that guideline because, for example, it wasn't said that way. You are a specialist, you are trained, you are educated to think of it holistically in that, for the best interest of your of the person you have in front of you.
The guideline, what I want to say is the guideline, say you'll have them in community, meningitis. It really is to set a standard. You know how to manage suspected meningococcal disease in a child or an infant. But it's you're collaborating with the community paediatricians, the hospital paediatricians, to find the most efficient way of, because this is this process progresses quite rapidly. We're talking about hours, and that's what the guideline is there for. You can ski off piste, but the idea is it's not to educate. The guideline is not there to educate us. That's also is what I want to.
Okay. For example, some people that you have to take into consideration their cultural and religious views. So some people may not want a certain, let's say, medication because of the ingredients. It might go against their cultural beliefs, religious beliefs. So you have to take that into consideration. That's not going to be on a guideline. That's something that you will have to unpick during that consultation.
And sometimes you're not being guided by the patient. You're having to pick this up
by yourself.
The clothes that they're wearing. It's useful for you to ask,
or through your previous experience, for example, because you dealt with it in the past. Because an individual has advocated on behalf of their community about this is not what
acceptable,
we would like to do, and it's not acceptable. So you sometimes say, hey, hi, some other people.
Is this an issue for you? Yeah. So sometimes you have to be a signpost.
Initiate it and explore it. So sometimes, yes, you expect it is a conversation. You expect the other individual to take the initiative, but sometimes you have to invite them and make them feel comfortable and safe to express themselves. But the original point I was trying to say is that when you brought up AI, is that AI at the moment is through algorithms, as far as I know, and therefore it is more following that guideline and may take a very long time to understand and create a bespoke, individualized response. And I don't think we're there. Whether we're going to be there in the future, who knows? But right now, it is not.
Yeah, and not to get distracted by AI. It was, again, just to praise what I see my colleagues doing, that I think patients won't pick up on because they don't have that audio narration or the subtitles to understand what's going on behind the scenes. And these are the small things that I hope to highlight.
And again, your experience as someone who works, let's say, in a very specific location with a specific, let's say, population, take into consideration your background. You're a woman of different ethnic background, you will pick up things and you will bring forth things which another person may not, and an AI or an algorithm may not. Just how Bong will do the same in a different location with his individualized experiences and background and culture.
I mean, it's even picking up on facial expressions and the tone, the dropping of, or the cadence of someone's speech. You know, the extra pause and understanding, does that worry you? And, you know, that open-ended question. This is more Bong's area of expertise, not mine. But those can even be difficult for humans to pick up, hey? You know, you have to be a highly trained individual that's been educated about that.
It comes into almost a consultation skill, doesn't it? You're looking for micro cues. Some things might be intuitive, others you get taught or you learn over the course of the years, and that's the kind of specialization and experience that counts, that we need to hone over the years rather than
decades.
Something that can be taught overnight.
Don't downplay it. So, I mean, and this is why in the community, you have your sage, white-haired GPs, but there is a skill set that they bring too. That's not necessarily true. And well, I don't know whether that's still the case, but I hear of a lot of patients that just like their family GP because it's somebody they've established a long-standing relationship with.
I mean, certainly the current model of primary care, which means basically the GPs, but also including the first contact physios and the mental health workers and physicians associates and advanced nurse practitioners and everyone that I haven't perhaps mentioned even would be part of that group. And the benefit of that is that we tend to be able to harbor relationship with individual patients better because we do tend to see them over a number of consultations, and we get to establish that relationship a bit better perhaps than some of our secondary care colleagues or tertiary care colleagues who are very much restricted by available resources, and in this case we're talking about time, how long you can see them in a clinic for, etc. So it does make a difference, I feel, in our world certainly, that we can get to know them a little bit better and therefore, as you had mentioned earlier, personalize what may or may not be important to that individual. So for a particular 85-year-old person, statin may not be an important consideration, whereas a different 87-year-old might be. And that's something that numbers won't necessarily give us the answer for. And yeah, I think that does allow us a bit more personalization of.
I mean, separately, I wonder whether this country wants to move towards a more self-directed take of medicine. So I'm ready for this, so I'll come and seek it. Whereas what you do in the community currently is screening and monitoring and advising when certain interventions are required. I know that I get a lot of patients who come to me with knee pain, expecting an MRI, even though that's not necessarily clinically going to help with the management plan. The time needed to recover to return back to play. They still are wanting to direct their management. So that's an interesting evolution that I'm experiencing now. This need to be in the driving seat, whereas I think even when we were training, which was 20 years ago, there was this understanding that the doctor in front of you holds an immense amount of information and can tailor an appropriate medical management plan.
I think that probably is that probably could create a whole podcast on its own standing, wouldn't it? But I think it's very important to consider that our health system, as good as it is, does have flaws, and some of those flaws may well be that particular individual that you're seeing didn't feel served or didn't get the answer for whatever they're presenting with, in this case the knee pain, and therefore they feel the need for an
Oh, are you saying I'm not a great clinician? I'm a very good clinician. I think you need to come consult with me. Hey, I don't know what you're getting at.
But all I'm getting to is that it may well be that they've actually got to you having already tried to navigate the existing NHS system. And NHS system may have been able to diagnose the condition appropriately, but that didn't serve their expectation, and therefore they've come to see you. So it's not necessarily that as you say, the individual needs that test particularly, but it may well be coming from a different position in terms of why they're actually seeing you. It's not that they weren't happy about the situation having unresolved, or it might be that they weren't happy with the extent in which it has changed. It may well be a slightly different agenda altogether.
I hear you on that, and I do see those patients. There's a level of frustration of being mismanaged. I try and reframe it and say that as a sports and exercise medicine consultant, it's incredibly easy for me, but I am highly trained, and those individuals in A&E, or A&E currently isn't staffed in a way that probably looks after musculoskeletal complaints, and maybe that's not the place where they should end up. So I hear you on that. Yeah, I'll have to think about that further and get back to you. But it's true, it's true. How would you like to direct me? What would you like if in a year's time, if I've produced 24 podcasts speaking to a wide variety of specialists, surgeons as well as physicians?
Okay, so this will be coming from my perspective, working in primary care, and we of course communicate with the secondary. When I say primary care and secondary care, there is a
Explain to me what those are.
Yeah, so broadly speaking, primary care are the GPs, the physios, etc., the groups I've mentioned earlier, and perhaps some I've missed. Secondary
so it's
care,
community medicine.
Community medicine, indeed. And secondary care being the hospital medicine, outpatient clinics or admissions or otherwise.
And this is the NHS pathway you're talking about?
Mostly speaking, yes.
So there's also a parallel private care pathway, or primary care is still NHS?
Primary care is predominantly NHS, and perhaps just a little caveat to mention is that actually, whilst we are NHS by definition, we are all individual businesses. So we're private businesses with the main contractor being NHS, and therefore we are encompassed in the NHS brackets.
Oh my God, that's almost a podcast in itself. Because I know what you're talking about, but I don't want to missell NHS GPs and people mistakenly thinking that they're businesses and maybe opening up a can of worms. So I think I'm going to note that down. That's definitely a topic I want to explore. But do you think it's important? So that's an interesting thing. Do you think the business model of how the NHS works is important? Do you think we need to educate the public, medical students, GPs and specialist doctors?
So certainly for those who are thinking about going into general practice, I think it's very important to know.
So you would like a podcast on that?
For the groups who are thinking about entering general practice, so that might include the foundation year doctors and medical students.
Is it important for the general population? Sorry, I have this incredibly bad habit of talking over people. So I apologise. But do you think it's useful information for the general population?
I mean, it might be interesting, but I think there's just such a wide scope of misunderstanding to happen there that I don't think perhaps it is all that useful or important for the general public to know about it. But perhaps just to be more aware that just because the term NHS is used, it does not mean one size fits all.
Okay, thank you for that explanation. What I was trying to get at was that we have the private system and the NHS system. So the NHS is primary care, so that should hopefully be ease of access to see your GP, and then perhaps, if recommended, a secondary care referral. That's a specialist consultant who'll see you in mainly the hospital setting, and that secondary care consultant, if it's a really rare disease entity, send you to a tertiary care centre. But what I wanted to explain was, how do I fit into it as a private care specialist consultant? It depends what what specialist consultant you are. But as sports and exercise medicine, I can get a referral from an NHS GP, but insurers are also allowing you to speak to an online GP or an online physio to then get access to me. Do you have anything to add to that? That very basic structure and that I've tried to paint.
Yeah, so I think it slightly divulges from the traditional British medicine structure, doesn't it? That it used to be NHS would do most, and those who can pay will go private. I think that's slightly shifting now, because it's not the need, there is the want section that's starting to expand, and that might be partly because of the social media or the availability of information or more awareness about individuals' health and options available out there. On top of that, there's the whole political side to it, which I'm not going to go into in great detail because perhaps I'm not the best person to be speaking about anyway. But, NHS is buying private capacity because there isn't enough resources within the NHS setting to be able to cater for the demand. And so there will be the use of private medicine through that bracket as well. All in all, quite frankly, excuse me, at the end of the day, as long as that individual gets seen by the appropriate person for appropriate reasoning and provided the appropriate management plan, that's what we're aiming for.
Sorry, I've forgotten why we even got into this, explaining
it was about the primary, secondary and tertiary cares and what you would like to see in a year's time, what I would like to see from your
Thank you for
podcast in a
reminding
year's
me.
time.
I think one feedback is Brinda, have a pen and paper so you can
Yeah,
take
I
notes.
think agenda, probably, running of it. Honestly, I think as we have opened, I'd be very happy to see the little pearls, nuggets of information that comes from different specialists that you find might be normal.
So it's a
but
20-minute podcast.
Yeah.
5 minutes maybe introduction and closure, and then 5 minutes for population education,
Indeed.
GP education, and then specialist education. Is that a pearl? Is that pearl sized?
I think that would be useful. And perhaps even to start with, whenever we talk about terms like this, primary care, secondary care, tertiary care, as you have just done there eloquently, actually explain what that means. That is effectively jargon. It's a medicalized term, isn't it?
Well, this is why having, ethnic minority mother helps. I don't take for granted that it's a given we understand everything.
Yeah, so I think that's why, perhaps you are in a very unique position to be able to
add to
provide
that
this.
joke, I still don't think my mum knows where I work. She certainly didn't follow me as I was going through my junior doctor training.
In all fairness, it's very hard to keep track of anyone's junior doctor training, isn't it? 'Cause you're
Yes.
flying left, right, and centre.
Yeah.
So yeah, I think that would be a good starting position. And if I was to be a bit
Sorry, can I
greedy-
also say, because I don't want to cut that out. I'm not being un-PC by saying ethnic minority mothers know nothing. But I'm saying,
Yeah, definitely not saying that.
I'm not trying to say that. And I'm using the example of my mother because there's, of course, a lot of admiration and love there. What I'm trying to say is she wasn't scientifically trained. She went to secondary school. There wasn't any higher education. So it's understanding that, individuals need bespoke levels of information. And it's being able to cater for that. So even though I might be classified as a highly educated individual with postgraduate qualifications, it's being able to relate on a different level. Yeah. Not just a professional level.
Sometimes even within us, even as a friendship group, we may not know your journey towards your training and where that took you, what centers, what kind of education, and then the GP training can be very different. You had these really protected teaching sessions and events which we weren't exposed to in the hospital setting, and we may not be aware of that unless it comes up in a conversation or we are exposed to GP trainees. We may never
Well,
know.
true. I mean, Bong, do you know how many paediatric allergy specialty training numbers there are?
Not a clue.
I don't, because did tell me now I was...
It's variable. It's like nationally could be 1 year might be 1 or 0, or at one point it was 4. So
So cause is a rare breed is what I'm trying to say.
very rare
Oh, we knew that.
in all forms. But and that's a completely different type of training that we have in the UK, which is very different in Europe, which is very different in the US and other countries. And our training is very, as a GP as well, and sports medic consultant, it's very different. So that comes back to what you were saying about having parents from abroad. They know their experience of perhaps of training or what a medical doctor is from their experience, from their upbringing, which may be completely different to what it is in the UK. Which then brings me to the next point, is that sometimes when you're seeing a patient, they may be from a foreign country, and therefore they have different expectations and different ways of navigating that healthcare system, because it's very different from where they were from.
So clear explanation, that's one feedback. So don't take for granted that medical jargon is widely understood. I'm aiming for a Radio 4 listener, but I want to cast that net wider if possible. This isn't light listening, it's not that entertaining, but I do want to share what gems we have. Any other tips?
I think it probably is a very short summary and maybe further reading or something like that about those topics. So it's almost like you're linking
a hyperlink in my explanation
example,
of the...
in some form of podcasting, they may have a little script and they may say, this is what is available.
And AI is perfect for this, guys. Yeah.
And to, one, have the abbreviations, have links, and recently timestamping on the different conversations.
Okay.
Yeah,
In terms of content, though, Bong, from a GP's perspective?
So one of the things, and I don't want to open up, again, a can of worms here, really, I suppose, but one of the things that I would like to improve on, and if this would help with that, that'll be excellent, is, I suppose, a working relationship between the GPs and the consultants, because a lot of times, well, not a lot of times, maybe that's a bit of an exaggeration, but occasionally you do have sort of letters going through which I suppose gets lost in a bit of translation. It might sound overly aggressive or overly demanding or overly unreasonable, and that's not really where we're coming from at all in either case, I'm sure. And perhaps the current system doesn't allow for that level of communication anymore. And
well, you're speaking to a specialist NHS doctor right now, cause I'm sure he shared some stories of how GPs may or may not facilitate care. So yeah, I do want to bridge those gaps, not just with the clinician and the society, but I want to help bridge that gap between specialists, secondary care doctors, primary care doctors, private practice doctors. I want to bring us together because I think we're a wonderful body of individuals.
So that would be great.
Okay. Anything else, or is that your final tip?
I'm sure there's lots, but you're putting me on the spot now. I'll leave it with that, I think.
Thank you. Thank you very much, Bong, for coming all this way, for giving your time, for...
My pleasure.
For being a wonderful friend.
And likewise.
Thank you. Okay. Thank you, guys.